what would indicate the patient is not tolerating a weaning trial? And it gives you a list. So a lot of them make sense, right? Respiratory rates greater than 30 per minute. So that's for 5 minutes or more. Sometimes the respiratory rate can go up because the patient's excited or they're trying to communicate with you and they're fine. They just got excited and the rate goes up. So if it's sustained 5 minutes and longer, that's a sign that they're not tolerating weaning. O2 sats are less than 90 or they've dropped 4% from their baseline. That's an indication they're not tolerating the weaning. Their tidal volume is decreasing. So if they're breathing on their own and their tidal volumes were 400 when you started the trial, and then you see it's 300 and it's 250, they're wearing out. They're just getting tired, and that's why their volumes are small. Blood pressure changing significantly. Some patients will become hypertensive, some can become hypotensive. The heart rate increases more than 20% or it exceeds 130 per minute. Or if the patient has PVCs, those are premature ventricular contractions. They're like a wide-looking rhythm. So you'll see normal rhythm on the monitor, and then you'll see a big wide complex. That's a premature ventricular contraction. And that occurs when there's irritability with the heart, as can occur when somebody is distressed when you're weaning them from the ventilator. They're not tolerating weaning if they become diaphoretic. It's an indication that they're working too hard to breathe. And then it says excessive anxiety or increased work of breathing. And they look anxious, and they see you walk past the room and they're calling you in, and you see some accessory muscle usage. Then they're not breathing well. The CPAP pressures. But if none of that is occurring and they're doing well, they're oxygenating well, they're ventilating well, whatever disease process occurred has been fixed, maybe you can wean. So to extubate a patient, and when you pull out the tube, it's possible that there was a lot of swelling in the airway that you don't know about when the endotube is in place. But as soon as you get the tube out and that swelling just increases and closes up the upper airway, you're going to see stridor and difficulty breathing immediately as soon as you pull the tube. So there's a way to look out for that, and that is to check for a cuff leak. So make sure you suction the oropharynx, make sure you suction above the cuff, and you will take all the air out of the cuff, and you should hear air leaking up into the oropharynx. If there's no air leaking up into the oropharynx, that tells you that you've got a lot of swelling in the upper airway, and it would not be a good idea to extubate the patient. So decrease, suction oropharynx, suction above the cuff, deflate the cuff, listen for an air leak. If there is none, indicates a swollen airway. So airway is not patent, do not extubate. Is the patient able to protect their airway from aspiration? This reason is why we prefer the neurostatus to be awake, alert, and oriented, because then they will be able to protect their airway. Somebody that's unresponsive won't protect their airway, and then they're liable for aspirating secretions. Are they able to clear secretions? They should elicit a strong cough, so when you suction the airway and you hit the carina and you notice them coughing strong, that's an indication that they can cough well and they will be able to clear secretions when you extubate. So if you can't extubate the patient, consider a tracheostomy. In patients who can breathe well, but they can't be extubated because they won't protect their airway. So this is the patients that are unresponsive, or they've had a stroke and their upper airway is flaccid. Maybe they're breathing fine, but they won't be able to protect their airway. So a tracheostomy would be recommended for those patients. And that way, you've got access to suctioning. If they do need to go on the ventilator, it's easy to just put air in the cuff and hook them up to the ventilator, versus having to re-intubate them. All right, here's a scenario. A 32-year-old female with streptococcal infection that affected the heart valves required open heart surgery to repair her mitral valve and aortic valve. She is currently 2 weeks post-op, being ventilated with the Avia ventilator. Her settings are PRVC mode, the rate is 10 breaths per minute, tidal volume is 600 ml, I time 1 second, she's on 40% and 5 Her neurostatus, she's sedated with Precedex. She follows commands but becomes very anxious when off sedation. Her hemodynamics show that they're stable, so we've got good blood pressure, heart rate 100 per minute, good renal function, good fluid status. So we're not going to be expecting any extra fluid to be in the lungs, making it difficult to breathe. Her respiratory status shows that her peak pressures are 44 centimeters of water. The plateau pressure is 38 centimeters of water. The minute ventilation is 12 liters, and her total respiratory rate is 20 breaths per minute. ABGs are 7.40 pH, PaCO2 34 millimeters mercury, PaO2 75 millimeters mercury, bicarb is 20 with a -3 base. Weaning parameters are done, and her rapid shallow breathing index is 120. Her vital capacity is 600 ml. Her negative inspiratory force is -25 centimeters of water, and her respiratory rate is 35 breaths per minute. So just looking at all that information, is there anything there that would make you think she might not do well if we extubate her?
Anxiety when off sedation.
Okay, so anxiety,
The rate of CPAP
her respiratory rate,
and vital capacity.
the vital capacity is small, RSBI is high, minute ventilation is high.
And the pressures are high too.
Yes. Yeah, so when somebody has stiff lungs and you let them breathe on their own, they are going to be very anxious and they're going to have a very hard time breathing. Those are really stiff lungs. Somewhere along getting the heart surgery and getting those valves fixed, and now there's something going on with her lungs for the lungs to be that stiff afterward. All right, so good, you found everything. Oxygenation, she's got a 75 PaO2, does it give us?
The saturation is
She's on 40% and 5 of peak. And her PaO2 is 75. I guess that part's acceptable, right? We want it to be greater than, a SAC greater than 92, PaO2 greater than 60, and it is on 40% and 5 of peak. So oxygenation is okay. Yes, she's working hard to breathe, but she's maintaining a normal blood gas. However, we know she's just going to wear out if we extubate her. We expect her to breathe on her own. Evaluate the data to predict the weaning outcome. So we just did that. She would not do well. Do you want to write it down, or you already have it written down?
do it again.
All right, so what did we mention? We mentioned
She has stiff lungs.
stiff lungs,
High pressures.
high pressures, go with the stiff lungs. RSBI is high,
High minute ventilation,
high minute ventilation,
low vital capacity, and a high RSPI.
yeah, low vital capacity. I think we mentioned RSBI already. and high respiratory rate.
On point.
You guys are twins, you know? You didn't even plan that, did you? I think we got it all. Now here's another scenario. We've got a 65-year-old male patient on a ventilator after being successfully resuscitated post-CPR. The patient is hemodynamically stable and is being managed with an internal pacemaker. His neurostatus indicates he is easily arousable and following commands. He is being ventilated with PRVC mode. The rate is 12 per minute, tidal volume 700 ml, FiO2 40%, he is 5. He is not assisting above the set rate, and his blood gas, 7.40 pH. The PCO2 is 34 millimeters mercury. The PaO2 is 85 millimeters mercury. Bicarb is 20 with a -3 base. Is that it for info? Yeah. Is this patient a weaning candidate? So was the initial problem fixed? His heart stopped.
Yeah, I
Did
think
it
so.
start up? Okay, so his heart's back. Does he have a good blood pressure post-resuscitation?
It's not.
Yeah,
but
it
he's
says
It
stable.
says he's hemodynamically
stable,
stable.
so that's good enough.
Yes.
So good blood pressure, heart's beating again, he's got a pacemaker. What about neurostatus? It's following commands, so is it good to extubate somebody that's following commands? Yes. And then, is he oxygenating okay with 40% and 5 with peak? Yes. Does it give us, it doesn't give us airway pressures. So I guess we just have to go with what we've got. Yeah, somebody who codes, you put them on the ventilator, and now they've got a heart rate again, their blood pressure, everything is stable. Got a pacemaker in. Most likely, there was nothing wrong with their lungs to begin with, it was just the heart that stopped. So you wouldn't expect high ventilating pressures. You wouldn't expect ARDS type lungs. So,
There's a slide that tells us when they do the CPAP trial.
all right, so he is a weaning candidate because the situation has been reversed, neurostatus is good, and we're oxygenating well. All right, so the patient is placed on a CPAP trial with pressure support of 8, is 5, FiO2.4. The monitored parameters are respiratory rate 25 per minute, SpO2 96%. So far, are we good? Does the respiratory rate of 25 per minute bother you?
Could be better.
It's less than 30.
Okay, good. Yeah, so 25 per minute, it's okay to still consider extubating. Spontaneous tidal volume, 375 ml. Is that about normal for adults? Like when we figured everybody's spontaneous volumes in here? Between 300 and 500? Okay. Rapid shallow breathing index, 67. Good. Vital capacity, a liter. That's good. Negative inspiratory force, -45. That's good. Blood gas is normal. Should we extubate? Yes. Yes. All right, good
How would you calculate the RSVI?
Do a 8.5 divided by,
Is that what you're asking? Oh, I'm sorry. You beat me to it. Go ahead. It's got to be on CPAP. We've got to be breathing spontaneously only, so you can't be doing it on a rate from the ventilator. It's got to be a spontaneous respiratory rate and a spontaneous tidal volume.
On the last one, it says the respiratory rate is 25. So it'd be 25 divided by 20. Or does the net give you the RMB? No?
You have to calculate.
Can I go on there?
You're saying, it's telling you that the patient is breathing 25 per minute
Yes.
on CPAP, and the spontaneous tidal volume?
375.
So when you put tidal volume into the equation, it has to be in liters, so it's going to be 0.375. So it'll be frequency or respiratory rate divided by the tidal volume.
That gives you, 66.6.
Oh, I see, it doesn't say 66 on the,
No, it does.
Seven.
66.6.
oh, so what if I give you a test question and I add stuff to that? Like the peak pressure, what are some other things I do? The FiO2,
I can tell who you use.
yeah. Does any of that information matter?
No.
No. So you just need your respiratory rate and the spontaneous tidal.
What if you make us calculate this one to
That would be fun.
Wait, that should be.
Thanks, Danny.
Okay.
I just thought about this.